So normals, and we'll talk about the normals. Normal CSF, the white blood count should be 0 to 5. Glucose should be 40 to 70. Now glucose, let's go with this. So CSF is formed for, we're basically filtering out our blood, and in glucose, it should be 2/3 of what your blood glucose is. So if your blood glucose is 300, 2/3 of that. So the normal isn't going to be 40 to 70 for that patient. Is not going to be normal, it's not going to be 40 to 70, because it's 2/3 of what the blood serum glucose is. Protein should be less than 40, and we're going to talk about how that can be wrong too as we get older. Bacterial meningitis, white blood count can be greater than 1,000, glucose less than 40, and protein greater than 250. Originally, his fault is the bacteria was eating the glucose, but more likely it's the bacteria is blocking the glucose from coming in from being filtered from the blood system. CSF TB meningitis, white blood count from 100 to 500, glucose less than 45, protein from 100 to 500. These are just kind of norms. It's not perfect because the fact of you can have somebody who has bacterial meningitis that has a white blood count less than 1,000, and they will come up positive on the PCR. The PCR is a game changer. You have to remember too is this, if someone receives antibiotics before you do a LP, the spinal column gets inoculated pretty quick. It's 6 to 8 hours in some studies. CSF for viral meningitis, white blood count from 10 to 500. Glucose is going to be about a normal range of 40 to 70. Protein less than 150. Here again, this is where the PCR has become the game changer. CSF for Guillain-Barré syndrome, you're going to have a white blood count of 0 to 5, so basically no changes. Glucose is going to be normal. And the protein is going to be a little bit higher, so 45 to 1,000. That's in Guillain-Barré. Let's talk about these newer studies that show upper limits for CSF protein are too low. In the absence of other CSF abnormalities, mildly elevated CSF protein is not clinically important. Why is this important to you? Now that you have the patient portals where family members or the patients themselves can look at the labs, and what do they look for? Red numbers. And you can do an LP, and the LP is perfect. And an older patient is going to hold a higher protein. It's going to say, oh, the CSF protein is elevated. They may say, and you say, well, it's normal. And they're going to look at you and go, I see the red numbers. You're an idiot. And you have to give them the further data and further workup that shows this. Yes, in older people, the cutoff should be changed. And hopefully this will have change to it. Various factors influence a laboratory's choice of normal limits. Usually laboratories, what they do is they get the norms in your community. 2 large commercial labs and 6 labs in major medical centers. This was the testing on this. Mayo Clinic uses 35 at the lowest upper limit of normal. So it's kind of all over the place. Most labs use 45 as we discussed. 2 labs adjusted upward for 60 or 70 in older patients. And there probably should be an adjustment based on the study. The study was in 2023. Most labs should raise upper limits of normal, should be adjusted for age. So this is something that you're going to have to work through until this gets adjusted, is that the study shows is that patients who are older are going to have a baseline elevated CSF protein, and this is the new normal for them as they get older. The reason why this becomes important to you is because these patient portals will show a red letter number. The red letter number is, oh my gosh, this is when the families get alarmed, and then we have to move forward with this. Bacteria to consider meningitis. Bacteria to consider in meningitis. Less than 50 years old, Neisseria meningitis, Staphylococcus pneumoniae, and the treatment would be vancomycin plus ceftriaxone. The ceftriaxone dosing is specifically 2 grams Q12 hours. Greater than 50 years old, we have to start thinking about Streptococcus pneumoniae, Neisseria meningitis, and E. coli, Klebsiella, Enterobacteria, Listeria. That's the big one, and we have to change what we're doing is add vancomycin plus ceftriaxone, remember 2 grams Q12 hours, plus ampicillin. Ampicillin is going to help us with the Listeria. Sterilization of CFS occurs 4 to 6 hours after initiation of IV antibiotics. That's why it's so important, if you can, is get that LP as soon as possible. Remember, on the LP, you have to first get a CT head to make sure it's safe to do the LP. We don't want to have any signs of herniation, and then you make things worse by doing the LP. So then you go from herniation to death. That's exactly, remember, first do no harm. Bacterial meningitis management. Empiric therapy is often initiated before CSF results are available because sometimes it takes longer. Now with the PCR, it's incredibly fast. It's so much faster. It is a great system. It's made a great change in what we're doing. So we want to give dexamethasone if we know this is going to be a bacterial meningitis. But here again, we're going to talk about how this has changed too. This helps reduce the neurological complications for strep pneumonia meningitis. The dexamethasone allows the antibiotics to penetrate better. You would give a dose of steroids 15 minutes prior to giving the antibiotics in full course, and it's 0.15 milligrams per kilogram Q6 hours for 4 days in those with confirmed pneumococcal meningitis. So what happens? You gave dexamethasone to a patient with viral meningitis. What happens? Did the patient spontaneously combust? No. Say dexamethasone, what they did is retrospective studies, is dexamethasone first before dose of antibiotics is beneficial in pneumococcal or Haemophilus B. In this study, patients with viral meningitis, the provider didn't know, and there's no way to really know. They're trying to do their job. They gave dexamethasone before it was found out they had a viral meningitis. So they got and there was no harms to the patient. So need to rule out as soon as possible because we want to stop the dexamethasone. We don't want to continue the dexamethasone on a viral meningitis, but if you happen to give a dose, it's not the end of the world. It is not the end of the world. So maybe we give ourselves more grace to give dexamethasone because you're not going to know right away and you need to give it before that first dose. Now, I've talked to see if there's any literature, can we give it after the antibiotic has been given? And this is just expert opinion. Expert opinion says maybe up to 6 hours. Say, for example, is the patient received the antibiotics in the emergency department, they come up to you and there's still 2 hours after receiving the antibiotics, they would say is potentially within that first 6 hours, there's no studies on this, it's just expert opinion, you can give the dexamethasone late. No evidence on this, but this is just something to think about because the dexamethasone does help, especially in pneumococcal. Now, once you know it's not pneumococcal, you can discontinue the dexamethasone and you won't receive further dosing. How about prophylaxis for meningococcal meningitis exposure? These are contacts. They have to be household members, close household members where you can get the sputum back and forth because you're talking to each other and spitting at each other. Daycare centers, school contacts, workplace contacts. Others with potential exposures, you have to have greater than 8 hours in a close proximity. This is within 3 feet. So even if it worked, are you going to have where you're going to have 8 hours where they're 3 feet within your face? 1 week before onset of patient symptoms, okay? So need to be greater than 8 hours, proximity of 3 feet, 1 week prior to the patient's symptoms. Anyone exposed to the patient's oral secretions. You would use rifampin, 600 milligrams BID for 2 days. What's the side effects of rifampin? Can have red discoloration of the teeth, urine, saliva, or tears. If they were in contacts, you can get discoloration of the contacts. Meningococcal vaccine should be also given to household contacts. All right, this is a new one that you may not have heard. And it's been around, but we're seeing it more because, well, we'll talk about it. Fusarium meningitis. This is by Fusarium solani. When do we see this? Medical tourism, specifically in Matamoros, Mexico, but it can be medical tourism anywhere. This is patients who have received epidural anesthesia. Maybe they're getting a butt lift and they needed the epidural anesthesia prior to the butt lift or another procedure. Symptoms can start weeks after the procedure. It's a contamination in the medication used in the epidural anesthesia. Maybe they're not using it, they're reusing needles. Diagnosis, lumbar puncture cell count assay for beta-lactam glutamate fungal, and getting that, also getting a fungal culture or PCR testing, and also getting imaging. You're going to need to have prolonged antifungal treatment. Fatality can be greater than 40%.